Oh, please help me. You have to help me. My husband, he's having an asthma attack and he can't breathe.
Okay, what's your address?
It's at 5228 Sugar Pine Circle.
5228 Sugar Pine Circle?
Yeah.
Okay,
You gotta help me.
what's your phone number there?
It's 687-4143.
4143?
Yes.
How old is your husband?
He's 32.
Okay, is he conscious right now?
Oh, barely.
Okay, is he breathing at all?
I don't know. I can't see his chest moving.
Okay, what I want you to do is stay on the phone. I'm going to dispatch the ambulance and come right back,
Okay,
okay?
hurry.
Okay, hold on. Attention McMinnville EMS, Delta response, respiratory arrest, 5228 Sugar Pine Circle. Repeating for McMinnville EMS, Delta response, respiratory arrest, 5228 Sugar Pine Circle. Welcome clear 1127, KDB 693. Okay, are you there?
Yeah.
Okay, how's he doing now? Is he conscious?
Oh, barely.
Okay, is he breathing?
He's falling down.
Okay, what I want you to do is listen to me really carefully. I'm going to tell you how to help him, okay?
Okay.
Okay, I need you to get the phone to him as close as possible.
Okay, let me go get him. Hold on.
Okay, I'm going to tell you how to do CPR.
Okay.
I need you to go do it now and don't hang up.
Okay, hold on.
Mike, I'm Medic 10's en route.
Medic 10, copy, you're en route. 5228 Sugar Pine Circle. You have a 32-year-old male. He's unconscious, not breathing at this time. CPR is in progress.
Medic 10, copy.
Okay.
Okay, is he there with you now?
Yeah, he's here.
Okay, listen carefully.
Okay.
I need you to lay him flat on his back on the floor.
Okay.
Okay, if he has any pillows under his head, you need to remove them now.
He doesn't have no pillows.
No one wants to face an emergency alone, without any training or skills. This woman was lucky to live in an area with highly trained dispatchers to assist her while help was on the way. In the Medic First Aid course, you will learn essential skills and build confidence so you won't have to totally depend on someone else. You will learn one consistent set of priorities in approaching and caring for an ill or injured person. These priorities are based on the body's need for oxygen and protection from further harm. You will learn the importance of caring for the mind and body. Your positive attitude and confidence can be as important as your hands-on skills in caring for a patient. You will notice that we use the word patient. A person may be a victim of an accident or illness, but once you begin caring for her, she becomes a patient, a person with feelings and emotions who is participating in the process. Over a decade of studies have shown that the low-stress learning environment in Medic First Aid contributes to a high rate of response in an emergency. Over 30% of you taking this course will have an opportunity to use your skills, oftentimes providing care for your family, friends, or neighbors. Much of the information you'll hear and practice today you already know. Allow us to help you put that information into a framework or context that will be easily recalled when you need it. The information will be presented in short video segments, followed by demonstrations and hands-on practice with mannequins and your classmates. Some of the video segments are graphic, such as the ones on control of bleeding and rescue breathing. This is to help you gain confidence in your ability to respond in a real emergency. Students who use their training often say the images replayed in their minds as they approach the scene. So listen and watch carefully. Take advantage of this time to gain new skills or increase your skills to protect yourself and others. Your instructor will use positive coaching and allow you to practice in groups of 3 as patient, rescuer, and coach. You will use a visual workbook to help learn the sequences of various skills. Your instructor will guide you through scenarios based on actual situations Medic First Aid graduates have faced following their training. Your instructor will also discuss the Emergency Medical Service System, also known as EMS in your area, and help you prepare an emergency plan for your home. By having no more than 12 students per instructor, you will receive the individual attention needed to develop your skills. Your student reference manual will help in building your framework of knowledge during class and serve as a refresher following class. Providing care in an emergency can be emotionally difficult, especially if severe injuries are present, patients are not resuscitated, children are involved, or multiple casualties exist, such as in a disaster. Caring for family members can also be difficult. It is natural to be shaky following an emergency. This is from leftover adrenaline, which helped you respond and perform. Light exercise, such as walking, can help use up this adrenaline. Talking about the incident and sharing your feelings will help with the emotional aspects of providing emergency care. Don't be afraid to ask for help if you found the emergency to be traumatic. Take comfort in knowing that you assured the patient received the best care possible in those circumstances. Your successful completion card and wall certificate demonstrate to others your willingness to respond in an emergency. Refreshing your skills and knowledge on a regular basis will prepare you to act as the critical first link in the chain of survival. An emergency scene can be dangerous for you as a rescuer. If you feel you are unable to safely begin caring for a patient, activate EMS and describe the situation so they can dispatch the appropriate resources. To assist you with a decision about whether or not to render aid, we have developed a simple method of assessing the accident or emergency scene. This scene assessment is called setup. The word setup stands for stop, environment, traffic, unknown hazard, protect self and patient. Remember, occasionally the scene itself can be the rescuer's biggest hazard. The sense of urgency may cause you, the trained rescuer, to feel pressure to respond. However, it is important to assess the scene. Let's look at setup more closely. The S stands for stop. Take a moment. Review the scene. Is the scene itself hazardous? Is it the reason the person became a victim? If so, you must protect yourself from becoming a victim too. Think mechanism of injury or illness. Anticipate injuries or problems which are likely. Think primary assessment. Environment. Is the environment at the scene a possible hazard to you? Do you have the proper clothing and equipment to protect yourself while responding and caring for the patient? Know the risks. Evaluate the environment. Consider your limitations. Traffic. At the scene of a vehicular accident, consider the pattern of the traffic. Use your vehicle's flashers to help protect the patient and warn other drivers. Use bystanders to flare the scene, flag traffic, and call for help. Remain alert to traffic hazards. Controlling traffic will reduce the hazard to you and the patient. Unknown hazard. The unknown hazard can be more subtle. Check to see if there are any unexplained fumes, gases, smoke, or clouds in the area. Is there any possibility of electrical hazard? Are wires down? Is the equipment at the scene run by high power? When a worker collapsed recently in an underground vault, 3 co-workers went in, one at a time, to rescue him. All 3 collapsed, becoming victims themselves. The 4th rescuer put on a self-contained breathing apparatus and protective clothing. Only 2 of the 4 workers survived. Your own safety must come first. You are of no help to the patient if you are injured. Take time to protect against unknown hazards. Protect yourself and the patient. In some circumstances, the patient could also be a hazard. The patient could be a carrier of a communicable disease, such as hepatitis or HIV. Take time to protect yourself with gloves, face shield, mask, and mouth barriers. It takes less than 60 seconds to put on protective barriers. Do it each and every time you respond to an emergency. Decide if you can perform rescue or patient care safely. Protect the patient also. Treat patients in the position in which they are found. Move patients only to protect them from life-threatening situations. Remember, setup means stop. Environment, traffic, unknown hazard, protect self and patient. Don't fall for a setup. The life you save will be your own, and perhaps the patient's life as well. The last step of setup is protect yourself and the patient. A large part of this protection comes from the use of barriers. Such viruses as hepatitis B and HIV can be transmitted from one person to another. The following steps are designed to minimize the risk of such transmission. First, assume that all persons are carriers of infectious disease. This includes adults, children, and infants. A person can be a carrier of disease without having any outward signs. Disease can be transmitted when the blood or body fluids of an infected person enter the rescuer's body through a break in the skin or through the mucous membranes, such as around the eyes. Use barriers such as gloves to protect your hands and wrists. An excellent way to test the gloves' integrity is to twist the gloves around themselves a time or two. Then hold the twist closed while you squeeze the air trapped inside. This will reveal weaknesses that might exist in the fingers or body of the glove. To put on the gloves, fold the cuff of the first glove back so you can grab the cuff as you pull the glove onto your other hand. Put on the other glove in the same way. Once the gloves are on, they provide excellent protection. If your gloves become torn, simply use another set. A non-fogging eye shield, face mask, and a gown may be important depending on the circumstances. One wrestling coach was sprayed with blood when a wrestler with a bloody nose sneezed on him. In addition to avoiding direct contact with blood or body fluids, avoid touching surfaces which have been contaminated with blood, such as these metal shavings or this cutting machine. Avoid punctures from sharp objects, such as broken glass and needles. Change gloves between patients to avoid transmitting disease from one person to another. Remove contaminated barriers in a manner that avoids blood or body fluids contact with your skin or mucous membranes. When you have finished caring for a patient, place the contaminated waste in the proper container for disposal. To remove your gloves, grasp the first glove from the outside only. Slip it off the hand by turning it inside out. Be careful not to snap the glove. This could splatter fluids. While still holding the first glove, slide your other hand inside the remaining glove. Slip it off in the same manner. This will slide the first glove inside the second as you remove it. Place your gloves in the appropriate container for disposal. Immediately wash your hands and any areas of possible exposure with antimicrobial soap and water for at least 2 minutes. Rinse your eyes if appropriate. Follow the Centers for Disease Control guidelines for cleanup of blood spills and contaminated surfaces. Special kits are available for such cleanup. Following cleanup, dispose of infectious waste according to local regulations. If exposure occurs on the job, contact your supervisor immediately for follow-up guidelines. If exposure occurs off the job, you may wish to contact your local health department for follow-up advice. Taking these precautions can greatly reduce your risk of contracting an infectious disease while performing emergency care. Primary assessment is a step-by-step method of determining the life-restoring and sustaining needs of the patient. Your assessment will cover the circle of care: arousal, airway with spinal protection, breathing, circulation, control of bleeding, and shock management. As we mentioned previously, the cells of the human body require oxygen. Oxygen is necessary for the production of energy. Without oxygen, the cells will die. Oxygen is taken into the body by the process of breathing. Oxygen is drawn into the lungs, where it is transferred through millions of tiny air sacs into the bloodstream. The heart then pumps the oxygen-rich blood to the body cells. Breathing and circulation are the oxygen delivery system for the cells. The body has priorities for the use of oxygen. The brain is the organ most sensitive to the lack of oxygen. Brain cells may die in as little as 4 to 6 minutes without oxygen. Other body organs, such as the heart, lungs, kidneys, and spinal cord, also require continuous supplies of oxygen. The muscles are less sensitive to the lack of oxygen and can continue to function with a reduced oxygen supply for some time. Your priorities of care are based on this need for oxygen. Primary assessment will help you identify and correct problems which interfere with the delivery of oxygen to the body cells. Now let's look at the steps of primary assessment. When you come upon a person who appears ill or injured and have assured a safe setup, begin by stating, "I am medically trained. I can take care of you." This will help reassure the patient. Do this even if the patient appears to be unresponsive. She may still be able to hear you. Then tap her on the shoulder and shout, "Are you okay?" As the oxygen supply decreases, her ability to respond is affected. The patient may be considered responsive when she answers in some meaningful way when spoken to, even though she may be disoriented. Monitoring changes in the level of responsiveness will give you valuable information on the patient's condition and care needed. If the patient does not respond to your tap and shout, you or another rescuer should activate the EMS system immediately. The primary assessment is performed without moving the patient. If the patient has been injured in an accident involving significant force as shown here, one must assume that there is also head, neck, and spinal injuries. You do not want to aggravate injuries by moving the patient. Since this patient did not respond to your tap and shout, you will need to assure an open airway and check for breathing while at the same time protecting the spine. The tongue is the most common blockage of the airway. At lower conscious levels, the jaw muscles relax, letting the tongue fall against the back of the throat. To pull the tongue from the back of the throat without moving the patient's neck or spine, you will lift the chin. Place one hand on the forehead to keep the head from moving. Place the fingertips of the other hand under the lower jaw on the bony part near the chin. Gently lift the chin. This chin lift maneuver helps raise the tongue off the back of the throat, opening the airway. In doing the chin lift, the fingers should not press into the soft tissue under the chin. The thumb should not be used for lifting, and the mouth should not be completely closed. With the airway open, look, listen, and feel for breathing. Place your ear over the patient's nose and mouth. Look for the chest to rise and fall. Listen for sounds of breathing. Feel for the flow of air on your cheek. If breathing is present, you will maintain an open airway. If breathing were absent, you would breathe for the patient using mouth-to-mouth ventilation. This patient is breathing, so your next step is to check for circulation by feeling the carotid pulse. To locate the carotid pulse, place 2 fingers on the windpipe. Move your fingers into the groove between the windpipe and the first fold of muscle. Gently feel for a pulse for 5 to 10 seconds. If the pulse were absent, you would begin chest compressions. In this case, the patient is breathing adequately, and the pulse is present. It is still important, however, to check the pulse for changes. Monitoring the pulse for changes in a breathing patient will help alert you to the patient's changing needs. Continue your assessment by quickly scanning the body for any serious bleeding. Uncontrolled bleeding is managed with direct pressure, pressure bandages, and pressure points while maintaining an open airway. Your next priority is the management of shock. Shock is simply a lack of adequate oxygen to body tissues. By assuring that the patient's airway is open, that she is breathing, her heart is beating, and by controlling any serious bleeding, you are managing shock by making the best use of available oxygen. An injured patient may have difficulty controlling her body temperature and become chilled. Assist the patient in these cases by helping to maintain a near normal body temperature, but do not overheat her. When spinal injuries are suspected, the patient should not be moved. As long as the patient remains unresponsive, you will continue to hold the airway in an open position without moving the head or neck. If a second rescuer is available, he or she may assist you by holding the patient's head in position while you maintain the airway and monitor the breathing and circulation. Make certain the patient continues to breathe at least 10 to 12 times a minute by carefully listening to the patient exhaling between breaths. Monitor the pulse in the neck. Recheck wounds frequently to assure bleeding has been controlled. Do not move the patient. Continue to perform your circle of care until help arrives. In any emergency, the EMS system should be activated as soon as possible. When turning the patient over to the responding emergency care providers, you will be able to relay valuable information on the patient's condition and care which has been provided. You have performed a valuable role as the first link in the chain of survival by initiating quality patient care. Your primary assessment may indicate the patient is not breathing, a life-threatening condition known as respiratory arrest. Rescue breathing with the mouth-to-mouth or mouth-to-barrier technique is a quick, effective way to provide oxygen to the patient. The rescuer's exhaled air contains enough oxygen to supply the patient's needs. There are many causes of respiratory arrest. They include drowning, electrocution, choking, severe allergic reactions, drug overdose, and trauma. Your primary assessment will help you identify respiratory arrest. If you see a person collapse or find someone who appears to be unresponsive and it is safe to approach, begin by saying, "I am medically trained and I can take care of you." Then tap him on the shoulder and shout, "Are you okay?" If he does not respond, activate EMS or your emergency plan. If you have no reason to suspect a head or neck injury, position the patient on his back in the face-up position. In such a case, you may use the head tilt chin lift method of opening the airway. Place one hand on the forehead and 2 fingers of the other hand on the bony part of the lower chin. Tilt the head back while lifting the chin. Do not allow the mouth to close completely. Remember, use the chin lift only with no head tilt if you suspect injury to the head or neck. If vomit or other fluids are visible in the mouth, remove them as quickly as possible. Look, listen, and feel for breathing. If breathing is present, maintain the airway in the open position and carefully monitor the patient. If breathing is absent or inadequate, you will need to breathe for the patient. If you have a barrier, you may quickly insert it now. While maintaining the airway, gently pinch the nose closed. Take a deep breath and place your mouth over the patient's mouth, forming a tight seal. Give 2 slow breaths. If your attempts to give rescue breaths are not successful initially or at any time during resuscitation, assure a good head tilt chin lift and try again. Improper position is the most common cause of difficulty with rescue breathing. If after repositioning and reattempting rescue breathing, the breath still will not go in, you must assume that there is a foreign body obstructing the airway. This is an uncommon situation, which we will cover in choking management. If the airway is unobstructed, give the 2 breaths full and slow to afford good filling of the lungs and to avoid placing some of the air into the stomach. After giving each breath, turn your head toward the patient's chest to take a breath of fresh air. Allow the patient to completely exhale between rescue breaths. If your breaths are adequate, you will see the chest rise and fall with each breath. You will feel and hear the patient exhale. Following the 2 slow breaths, you must determine if the patient's heart is beating. The most reliable pulse to use is the carotid pulse. While maintaining the chin lift, place your fingers on the windpipe. Move your fingers into the groove between the windpipe and the first fold of muscle. Gently feel for the pulse for 5 to 10 seconds. If the pulse is present, but the patient does not resume breathing, continue with rescue breathing, giving 10 to 12 breaths per minute, or approximately 1 each 5 seconds. The breaths should be delivered over 1.5 to 2 seconds each. The major complication associated with rescue breathing is air blown into the stomach. This problem can be minimized by keeping the airway open, using slow breaths, and limiting your breaths to the volume which makes the chest rise. Should the stomach become distended during rescue breathing, the airway should be repositioned and excessive breaths avoided. Continue rescue breathing and do not attempt to expel the air. Doing so may cause vomiting. If vomiting does occur, turn the patient's entire body as a unit to the side. Allow the vomitus to flow out. Return the patient to his back, assure a clear airway, and continue with rescue breathing. Monitor the patient's pulse to assure his heart continues to beat. Breathe for the patient until he resumes breathing on his own, until another qualified rescuer takes over, or until you are exhausted and unable to continue. Your breath of life may prevent cardiac arrest and allow the patient to return to a meaningful life. While developing countries often have other more pressing health issues, sudden death related to heart disease is the most common medical emergency in industrialized nations. If you see a person collapse or find someone who appears unresponsive and setup determines a safe approach, begin with your medical statement. Say, "I'm medically trained and I can take care of you." Then tap and shout, "Are you okay?" If he does not respond, activate the EMS system. Recent studies confirm that survival from cardiac arrest depends on a time-sensitive series of events. Early activation of the emergency medical services system is the first step you must take. If there is no reason to suspect head or neck injury, open the airway with the head tilt chin lift. Look, listen, and feel for breathing. If breathing is absent, you will need to give 2 slow rescue breaths. If you have a barrier, you may want to insert it. The 2 breaths are given slow and full to afford good filling of the lungs. Following the 2 rescue breaths, check for the patient's heartbeat using the pulse in the neck for 5 to 10 seconds. The absence of a pulse must be confirmed before performing chest compressions. Giving chest compressions to a patient with a pulse can result in serious medical complications. If the pulse is absent, the heart is not beating, and compressions are needed. Blood circulated to the lungs by a combination of proper rescue breathing and chest compressions receives enough oxygen to keep the brain and heart alive for a limited period of time. The patient must be on a firm, flat surface for chest compressions to be effective. To locate the correct hand placement, position yourself at the patient's side. With your middle and index fingers, locate the lower margin of the patient's rib cage. Slide your fingers up along the rib cage to the notch where the ribs meet the breastbone or sternum. With one finger on the notch, place your other finger next to it on the sternum. This is called a landmark check. Place the heel of your other hand next to the finger on the sternum. Remove the first hand from the notch and place it on top of the hand on the sternum. The fingers may be extended or interlaced to avoid pressure on the ribs. Position yourself with your shoulders directly over your hands and your arms locked straight. Push down on the sternum, compressing it 1.5 to 2 inches. Keeping your arms locked straight, completely release pressure, allowing the chest to come back to its normal resting position. Maintain contact with the chest to assure proper hand placement is not lost. Continue compressions at an even rate of 80 to 100 per minute. In order to achieve a speed of 80 to 100 compressions per minute, count out loud 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. The compression should be smooth, regular, and of equal time on down and up strokes. After each 15 compressions, move up to the patient's head, open the airway, and give 2 slow, full rescue breaths. Perform 4 complete cycles of 15 compressions and 2 rescue breaths. After 4 cycles of compressions and breaths, stop and check for a pulse for 3 to 5 seconds. If absent, resume the technique of compressions and breaths. Stop and check for the return of pulse and breathing every few minutes. Continue CPR until the pulse and breathing return, until you are relieved by someone with equal or higher training, or until you are exhausted and unable to continue. It is rare for CPR alone to restart the heart. Have a bystander meet the paramedics and lead them to the patient. Although CPR is valuable, it is only a temporary measure to keep the heart and brain oxygenated until an electrical shock called defibrillation can be delivered to the patient by trained providers. This electrical shock can often restore the heartbeat to near normal if delivered in time. The greatest survivability from cardiac arrest without brain damage occurs when CPR is started within 4 minutes and advanced life support arrives within 8 minutes. The chain of survival concept emphasizes the importance of early activation of EMS, early CPR, early defibrillation, and early advanced life support. However, because this series of events is so time-sensitive and EMS systems vary from community to community and state to state, current survival rates from cardiac arrest average only 15%. This means that in 4 out of 5 attempts at resuscitation, the patient does not return to life. Long-lasting physical and emotional symptoms have occurred in professional rescuers whose patients did not return to life. It is now recognized that follow-up care may be necessary to assist rescuers in working through their feelings. Recent studies confirm that rescuers often fear doing the wrong thing during resuscitation. Feelings of responsibility, anxiety, and guilt may follow resuscitation attempts. It is important to remember that a patient in cardiac arrest is essentially dead. No further harm can be done attempting to resuscitate one who seems deceased. Patients who are not resuscitated do not die. They stay dead. The purpose of basic CPR is to keep the patient's heart and brain cells alive until EMS arrives. In almost all studies, bystander CPR has shown a significant positive effect on survival. Providing CPR to a patient in cardiac arrest is the best treatment possible until professional responders arrive. Your quick assessment, early activation of EMS, and quick application of CPR will help restore the possibility of life.
Sudden death from choking claims several thousand lives each year. Fortunately, techniques have been developed that are very effective in saving the life of a person who is choking. You no longer need to feel helpless when a relative, friend, co-worker, or stranger chokes. You can help. Choking usually occurs during eating. 3 factors which contribute to choking are high levels of alcohol in the blood, dentures, and large, poorly chewed pieces of food. Most choking cases could be prevented if the following precautions were taken. Cut food in small pieces. Chew slowly and thoroughly, especially if wearing dentures. Avoid laughing or talking during chewing and swallowing. Limit alcohol intake before and during meals. Restrict children from running or playing with food or objects in their mouths. Keep small objects such as marbles, beads, and thumbtacks away from infants and small children. It is important to recognize the signs of choking so that you may act quickly. The person may grasp at his throat, the universal distress signal for choking. He may appear bluish about the lips or in the nail beds. Oftentimes, the person will be embarrassed and will try to leave the room. Do not let him do this. If you suspect that someone is choking, begin by asking, "Are you choking?" If he can speak, breathe, or cough forcefully, do not interfere with his attempts to clear his airway. Encourage him to cough and stay with him to protect him and help if it becomes necessary. If the partial obstruction persists or a total obstruction occurs, activate the emergency medical service system. If the patient cannot speak, breathe, or cough forcefully, or has a weak, ineffective cough and makes high-pitched noises while inhaling, you must act quickly. Use your statement, "I'm medically trained and I can take care of you." You will need to perform a series of manual thrusts to the abdomen. To perform the abdominal thrust, stand behind the patient and wrap your arms around his waist. Locate the navel. Make a fist with the other hand and place the thumb side of the fist in the abdomen just above the navel. Grasp your fist with the other hand and press inward and upward. These thrusts inward and upward force trapped air in the lungs up against the obstruction. This aids in forcing the obstruction out of the airway. Each thrust should be a separate and distinct thrust delivered with the intent of relieving the obstruction. The thrusts may need to be repeated up to 5 times to be effective. If the airway obstruction is not relieved and the patient remains responsive, recheck your hand position and reattempt thrusts until the obstruction is relieved or the patient becomes unconscious. Abdominal thrusts may cause vomiting and carry potential for injuries to the ribs, liver, and spleen if done incorrectly. For this reason, it is important to accurately determine that the person is choking and direct the thrust in a manner that avoids the ribs, liver, and spleen. In cases of advanced pregnancy or marked obesity, chest thrusts may be used as an alternative to abdominal thrusts. To perform chest thrusts with the patient sitting or standing, locate the notch where the ribs meet the breastbone or sternum. Place the thumb side of your fist on the middle of the sternum, taking care not to put pressure on the ribs. Grasp your fist with the other hand and give up to 5 thrusts. If the obstruction persists, reassess your hand placement and continue thrusts until the obstruction is removed or until the patient loses consciousness. If you are alone and you choke, you may try abdominal thrusts on yourself or lean forward and press your abdomen quickly and repeatedly over any firm object such as the back of a chair, table, or porch railing. Persons who have experienced a complete obstruction which was removed by means of abdominal or chest thrusts should be evaluated at a medical facility for possible internal injuries. If a choking patient becomes unresponsive while you are working on her, gently lower her to the ground. Assure that the EMS system has been activated. If you have barriers, you may wish to use them. With the patient face up, grasp the patient's tongue and lower jaw between your thumb and fingers and lift. This tongue-jaw lift draws the tongue from the back of the patient's throat and away from a foreign body that may be lodged there. This alone may relieve the obstruction. Using the finger of your other hand, slide down along the inside of the cheek and deeply into the throat. Then use a hooking action to move the object into a position where it can be removed. Take care not to force the obstruction deeper into the airway and never place your finger in the mouth of a patient who is having a seizure. Following the finger sweep, attempt a rescue breath. If the airway remains blocked, you will need to perform a series of abdominal thrusts. To perform abdominal thrusts with the patient lying down, straddle the thighs. Place the heel of one hand in the midline just above the navel. Place the other hand on top of the first. Perform a series of 5 thrusts inward and upward. Chest thrusts may be used when the unresponsive patient is pregnant or markedly obese. Perform chest thrusts in the same position as chest compressions for CPR. Each thrust should be given with the intention of relieving the obstruction. After giving the abdominal or chest thrusts, sweep the mouth and try a breath. If the airway remains blocked, repeat the abdominal or chest thrusts. Sweep the mouth and try a breath. Continue this sequence until the airway is open. Once the airway is open, give the patient 2 slow, full rescue breaths. Check the pulse and continue to provide the indicated care. As you learned earlier, the tongue is the most common cause of airway obstruction in the unresponsive patient. Thick or thin fluids such as vomit and mucus are the next most common obstructions. Fluid in the mouth should be cleared before attempting further care. It is possible, though rare, that you would come upon a patient who choked on a foreign object and became unresponsive. Your approach to the patient is the same. Assure a safe setup, give your medical statement, tap and shout to determine responsiveness. If you have barriers, use them. Open the airway with the chin lift maneuver. Look, listen, and feel for breathing. If there is no breathing, insert your barrier and attempt to give a rescue breath. If the breath will not go in, recall the main problem with rescue breathing, the tongue blocking the airway due to improper positioning. Assure a good head tilt chin lift. If the breaths will still not go in, you must assume something other than the tongue is blocking the airway. Use your series of 5 abdominal or chest thrusts, finger sweep and breaths until the airway is open. If at any time you clear the airway, reassess the patient's condition and provide the indicated care.
As you learned in primary assessment, the priorities in patient care are to assure a clear, open airway, adequate breathing, and adequate circulation. Your next priority is to control serious bleeding. Loss of blood can be a life-threatening condition and needs to be quickly recognized and controlled. An average adult body contains 10 to 12 pints of blood. The loss of 2 pints can produce shock, and a 3 to 4 pint loss can be life-threatening. In order to recognize when bleeding is serious, it will be helpful to have a basic understanding of the circulatory system. This system is composed of the heart, the blood, and the network of vessels through which the blood flows. The heart serves many important functions. Of primary importance is its ability to deliver oxygen and nutrition to the tissues and carry away carbon dioxide and waste products. When the blood flow is interrupted due to injury, bleeding usually occurs. The result is a lack of oxygen to body tissues. The body has a number of protective mechanisms, one of which is the clotting function of the blood. When blood flows from an injury site, specific properties of the blood cause formation of a network of thread-like fibers. These fibers create an artificial dam to hold back further blood flow. This dam is known as a clot. In many instances, bleeding will stop in 6 to 10 minutes on its own due to this clotting process. The type of blood vessel injured can be identified by the color and movement of the blood. Bleeding from capillaries oozes slowly and usually stops with little or no attention. Placing a dressing over the wound will help prevent contamination. Bleeding from veins is dark red and the flow is strong and steady. Bleeding from arteries is bright red and spurts with each contraction of the heart. Bleeding from veins and arteries can be life-threatening and must be controlled quickly. Assure setup and put on your barriers as you approach the patient. To control bleeding, start with direct pressure over the wound with a clean cloth or barrier. As first aid materials become available, add absorbent dressings on top of the existing dressings as needed. Blood will flow into the dressings and expand and clot to form an artificial dam. If the wound is on an arm or leg and other injuries would not be aggravated, you may elevate the limb for the comfort of the patient. When the flow of blood has been stopped, simply bandage these dressings in place tight enough to prevent slipping, but not so tight as to cut off circulation to the rest of the extremity. Do not remove the dressing. Bleeding that continues after the dressing is in place usually means that not enough direct pressure has been applied. When this occurs, simply apply additional pressure through the dressing. Add extra dressings and secure them with another bandage applied tighter. This method is the most effective way to control bleeding. When pressure dressings are not available, or when direct pressure and additional dressings do not control the bleeding, a pressure point may be combined with direct pressure. A pressure point is where the main artery supplying blood to the injury site lies near the skin and over a bone. Press the artery against the bone. This can greatly reduce the amount of blood flow to the injury site. Compression of a major artery rarely controls bleeding completely. This is because the wound is usually bleeding from more than one artery. A pressure point can aid in the control of bleeding and can reduce blood loss by indirect control of bleeding while barriers are being obtained. The current consensus is that tourniquets should virtually never be used to control bleeding in an emergency. Once bleeding has been controlled, continue to care for the patient by performing your circle of care. Recheck frequently to assure bleeding does not resume. When you have completed your patient care, follow the CDC guidelines for minimizing your risk of disease from blood-borne pathogens. Your skill in the control of bleeding while protecting yourself and the patient is a critical step in the circle of care. A continuous supply of oxygen is necessary for body cells to function. This oxygen is delivered to the cells by the circulatory system. An interruption in the supply of oxygen may result in a condition known as shock. The circulatory system consists of a container, the heart and blood vessels, and the contents, the blood. Normally, there is just enough blood to fill the system entirely. Problems in the circulatory system may occur due to heart failure, vessel failure, or content failure. when the heart fails, an inadequate supply of oxygen may be delivered to the tissues. Damage to the spinal cord, especially in the neck, can cause injury to the portion of the nervous system that controls the size and tone of the blood vessels. The arteries have muscular walls that allow them to expand or constrict depending on the body's needs. This action is controlled by the nerves. When the spinal cord is damaged, all of the vessels below the injury site dilate. This is known as vessel failure. When this occurs, there is no longer enough blood to fill the vessels. Large quantities pool in the legs and abdomen, reducing the supply of oxygen to the brain and heart. Internal or external bleeding reduces the volume of circulating oxygenated blood and may cause content failure. The mechanism or cause of the injury may lead you to suspect internal bleeding. Severe burns may also result in content failure due to the loss of blood or other body fluids. The first signs of shock, which often come before all others, is the patient appearing uneasy, restless, or worried. Other signs and symptoms include a rapid, weak pulse which is difficult to feel, wet and cold skin from heavy sweating, pale or bluish tissue color, shivering, intense thirst, nausea, and vomiting, and breathing becoming shallow or gasping. The care for shock is to make the best use of available oxygen. During your primary assessment, assure that the airway is open and breathing is adequate. For shock caused by spinal injuries, do not move the patient and do not raise the legs. Doing so could aggravate the injury. Do not raise the legs if you suspect fractures. In shock caused by loss of circulating content, such as bleeding, raise the legs 8 to 12 inches. This action allows the remaining blood to be returned to the heart and brain. When you suspect shock from heart failure, such as a heart attack, and the patient is responsive, allow him to maintain a position which is comfortable for him. Normally, he will want to sit up. Do not raise his legs, as this will put an extra burden on his heart. Fainting is often mistaken for shock. In response to fright, pain, heat, or other stimuli, arteries may dilate. This temporarily reduces blood flow to the brain, causing the patient to pass out. A person who has fainted usually regains consciousness rapidly when lying down, as blood and oxygen are then able to reach the brain. Raising the legs quickens recovery. However, because fainting can be a sign of a serious medical problem, anyone who suddenly faints should consult the paramedics or a doctor. In all cases, maintain a normal body temperature, but do not overheat the patient. Ask the patient if they are warm or cold and act accordingly. If necessary, place blankets under and over the patient, taking care not to aggravate any injuries. Do not give the patient anything to eat or drink. In all cases of shock, continue your circle of care. Remember, your job is to ensure that in all cases, an adequate supply of oxygen is circulated to body tissues. Caring for an ill or injured patient until professional rescuers arrive requires that you continue your circle of care. When you suspect head, neck, or back injuries, the patient should not be moved. Primary care should be performed in the position the patient was found. However, should the patient vomit or if other fluids in the mouth such as blood become a problem, turn the patient as a unit to protect the airway. Allow fluids to drain. Continue to closely monitor and protect the patient until help arrives. When the patient is unresponsive but continues to breathe on her own, and there is no reason to suspect head, neck, or spinal injury, you can help protect the patient's airway by placing her in the recovery position. Roll the patient onto her side so that the head, shoulders, and torso move at the same time without twisting. The patient's hand is placed under the face for support and the top leg bent slightly at the knee. In the recovery position, the patient's jaw lies forward so the tongue does not obstruct the airway. Should the patient vomit, fluids will be allowed to drain. If you must leave the uninjured and unresponsive patient to get help, place her in the recovery position. When EMS is readily available, continue to monitor and protect the patient's airway and spine, make certain the patient continues to breathe, and monitor the pulse in the neck for changes. Recheck wounds frequently to assure bleeding has been controlled. Maintain a normal body temperature and monitor the patient's level of responsiveness for any changes. A second rescuer, if available, should immobilize the patient's head and neck by holding it in position. By monitoring the patient and continuing your circle of care, you, the volunteer Good Samaritan rescuer, have become the golden link in the chain of survival.
Medical problems such as heart attack and stroke are described in terms of signs and symptoms. A sign is something you see, hear, or feel. A symptom is something the patient states. Illness assessment is the observation of these signs and symptoms. The body posts warning signs for you to read and observe, just like warning signs on a highway. If you understand what the signs mean, you can then take appropriate action. The signs you will use in illness assessment are pulse, respirations, skin temperature, and tissue color. Normal ranges have been established for these vital body signs. If you understand normal body signs, then abnormal signs are more easily recognized. Keep in mind that there is a wide range of normal. What appears abnormal to you may be normal for that person. In illness assessment, it is important to talk with the patient and look at the total picture. The pulse of a responsive patient is checked at the wrist. To find the radial pulse, use 3 fingers and press down gently between the bone and first tendon on the thumb side. The pulse is described by expressing what your fingers feel. A weak and rapid, fast and bounding, or irregular and thready pulse may indicate a problem. The pulse rate is determined by counting the number of beats in 1 minute. The normal resting pulse for an adult is 60 to 100 beats per minute and described as regular and full. Respirations or breathing rate may be counted by observing the movement of the chest or by placing one hand gently on the diaphragm. The rate is determined by counting the number of breaths in 1 minute. The normal rate of respirations for an adult is 12 to 20 times per minute. Breathing at rest is usually shallow, regular, and quiet. Problem breathing may have such descriptions as deep, labored, gasping, or noisy. Skin temperature is felt at the forehead and cheek using the back of the hand. Normal temperature taken by thermometer is 98.6 degrees Fahrenheit. Skin temperature felt with the back of the hand gives a comparison between your temperature and the patient's. Normal temperature at rest will feel neutral and dry to the touch. Abnormal temperatures may have such descriptions as cool and clammy or hot and dry. Tissue colors are accurately seen inside the lip or in the nail beds. Normal tissue colors are pink, pale, or ruddy, a dark red color. Tissue color reflects the color and amount of blood being distributed throughout the body. Certain shades of red, white, and blue may indicate a problem. Symptoms are statements made by the patient. Symptoms used in illness assessment are the patient's description of how he or she feels, medical alert tags, the patient's medical history, and a description of any medications prescribed for the patient. Careful attention to signs and symptoms will allow early recognition of medical problems and early access to EMS, increasing the patient's chance for meaningful survival. Diseases of the heart and blood vessels are a leading cause of death in Western civilizations. Understanding the signs and symptoms of two common heart problems, angina and heart attack, may aid in early recognition and treatment. The heart is a special type of muscle which needs a continuous supply of oxygen to pump effectively. The heart muscle receives its supply of oxygen from blood delivered by the coronary arteries. Plaque can build up on the inside of the coronary arteries and narrow the blood's passageway. This reduces the amount of oxygen received by the heart muscle. Normally, when a person is engaged in physical activity or is under emotional stress, the coronary arteries enlarge to allow delivery of more oxygen to the heart muscle. Angina is a condition which occurs when diseased, narrowed coronary arteries are not able to deliver enough oxygen to meet the demand. This inadequate supply of oxygen to a portion of the heart causes pain. Angina attacks are sometimes mistaken for indigestion or heartburn and ignored until they become severe. The major symptom of angina is pain in the center of the chest, which may radiate to the jaw, arms, or upper abdomen. The pain may travel down the left arm. This pain may last for several minutes, but rarely more than 10 to 15 minutes. Many people who have angina will carry a medication called nitroglycerin. This medication may come in several forms, including mouth spray, skin patch, or pill. Nitroglycerin causes the coronary arteries to dilate. This allows more oxygenated blood to flow to the heart muscle. A person having an attack of angina will need to stop all activity and relax. This will reduce the heart's demand for oxygen. If a person is having an attack of angina, see that he is in a comfortable position. If he has nitroglycerin, you may assist him in taking the medication as prescribed by his doctor. Usually, rest and nitroglycerin will relieve the pain. If the pain is not relieved by rest and nitroglycerin within 10 to 15 minutes, emergency transportation to the appropriate medical facility should be arranged. Continue your circle of care until additional help arrives. A heart attack is a more serious heart problem which occurs when one of the coronary arteries becomes severely narrowed or totally blocked by a clot, plaque, or a spasm of the artery. The portion of the heart served by that artery is starved for oxygen, and the tissue begins to die. Such factors as smoking, stress, and high blood pressure have been shown to increase the risk of heart attack. Signs and symptoms of heart attack are uncomfortable pressure, squeezing, or pain in the center of the chest lasting 2 minutes or more than 15 minutes in a known heart patient taking nitroglycerin. The pain of heart attack may spread to the shoulders, neck, arms, jaw, or abdomen. The patient may experience dizziness, profuse sweating, nausea, anxiety, and an overwhelming frightening feeling that he's going to die. He may have shortness of breath and appear pale or bluish inside the lip or in the nail beds. The pulse may be abnormally slow, fast, or irregular. Oftentimes, a person having these signs and symptoms will deny the problem and will delay seeing a doctor. This can dramatically reduce chances of survival. New drugs used to dissolve clots in the coronary arteries can stop a heart attack or reduce its damage. To be effective, these drugs must be given within 3 to 4 hours after the heart attack occurs. The greatest risk of death from heart attack occurs within the first 2 hours after the onset of symptoms. For this reason, you must insist on taking prompt action. Keep the patient quiet and quickly activate the emergency medical service system. Monitor the airway, breathing, and circulation, and reassure him. Continue your circle of care until additional help arrives. Advances in medicine and healthier lifestyles have played an important role in reducing the death rate from stroke. However, there is still room for progress. Stroke continues to rank as a major cause of death and disability. Recognition of early warning signals and prevention can help reduce the severity of this problem. High blood pressure is a major contributing factor to stroke. Checking your blood pressure on a regular basis and controlling it, if it is high, will help reduce your risk of stroke. A stroke occurs when an artery serving the brain ruptures or becomes blocked by a clot or buildup of plaque. The portion of the brain served by that artery no longer receives oxygen. Body functions controlled by the damaged portion of the brain are affected. Early warning signals lasting less than 24 hours are a good indication that a stroke may occur. They include sudden temporary weakness or numbness of the face, arm, or leg, temporary difficulty with or loss of vision, particularly in one eye, an episode of double vision, unexplained headaches, or a change in the pattern of headaches, temporary dizziness, or loss of balance. If you have one or more of these early warning signals, make an appointment to see your doctor. The signs and symptoms that a stroke has occurred usually appear suddenly. The stroke victim may suddenly have difficulty with vision or movement. He may have weakness, loss of feeling, or paralysis on one side of the body. Initially, he may appear flushed. He may then become very pale and his skin feel cool and clammy to the touch. The pulse, while initially slow and strong, may become rapid and weak. Breathing may be slow and sound like snoring, especially if the patient is unconscious. The ability to speak is often impaired. The patient may try to talk, but what comes out may be garbled or not make sense. This can be very frustrating for the patient. If this occurs, tell the patient that you realize that he may not be able to talk right now, but it's more important for him to relax and concentrate on his breathing. This may have a calming effect on the patient. Oftentimes, people assume that because a person cannot talk or appears to be unconscious, he also cannot hear. They make unnecessary comments about the patient that may frighten him and cause further stress. If family or bystanders are present, explain that you are caring for the patient and see that they do not make inappropriate comments. Have them activate EMS. The signs and symptoms of a stroke will vary depending on the portion of the brain affected, but the care of the stroke patient remains the same. See that a clear, open airway is maintained. Monitor breathing and circulation. See that the responsive patient is in a comfortable position and reassure him that you will take care of him. If the patient begins to lose consciousness, lower him to the floor and roll him onto his affected side. The recovery position will allow debris and fluid to drain out of his mouth. While you maintain a clear, open airway, assure that someone has arranged for emergency transportation by qualified medical personnel. While arrangements are being made, continue to monitor the airway, breathing, and circulation. Continue your circle of care for the patient until additional help arrives. An allergy is an overreaction by the body to a substance that is normally harmless. Some people, when exposed to substances such as animal hair, pollen, or dust, react with sneezing, watery eyes, and a runny nose. However, some people are extremely sensitive to a substance such as bee sting venom, and when exposed to that substance, may experience a severe, even life-threatening reaction. Exposure to these substances may come through ingestion, such as eating seafood, through injection of a substance, such as penicillin, inhalation of airborne substances, such as hay, dust, or pollen, or by stings from insects, such as bees or wasps. Once persons become aware that they are allergic to a substance, such as penicillin, they may be able to avoid contact with that substance. However, avoiding contact with bees and wasps may be more difficult. Reaction time to a substance may be gradual, taking 15 to 20 minutes. In some cases, reactions may even be delayed for several days. Or, the reaction time may be rapid, taking as little as 10 to 15 seconds, and unless treated promptly, death can result in a matter of minutes. The patient may experience generalized weakness, headache, abdominal cramps, nausea, and anxiety. The skin may feel hot and the patient complain of a burning, itching sensation. The pulse may be rapid and weak. The patient may experience breathing difficulty with wheezing, coughing, and gasping. There may be tightening and pain in the chest. There may be localized swelling as well as swelling of the face, eyes, tongue, and throat. Breathing may become extremely difficult and may stop. Without immediate care, the patient may die. As soon as you recognize that an emergency exists, notify the emergency medical service system of the problem and location. Provide primary monitoring and care if the patient becomes unresponsive. Some people will carry an emergency kit such as an ANAKit or the EpiPen, which contains medication to counteract the reaction. You may need to assist the patient in preparing for the injection. As with any prescribed medication, it should only be taken by the person for whom it was prescribed. Following directions in the kit, the medication is injected into the thigh. The syringe is held in place for several seconds. It is then removed and the area massaged for 10 seconds to aid in absorption of the medication. Following administration of the medication, reassess the airway, breathing, and circulation and provide the indicated care. If help will be delayed and the patient does not respond promptly, a second injection may be needed. Assist the patient in following the directions in the kit. If you're working in a remote location, it is critical that you have a plan for accessing the EMS system. Depending on the circumstances, you may take the patient to meet the ambulance, or EMS may come directly to you. Regardless, when you turn the patient over to the EMS providers, pass on information on the patient's condition and the care that has been provided. Your prompt action in such cases is essential and may help save a life.
Marcia, are you all right? Is something bothering you?
Oh, I'm fine. It's probably just a little indigestion from lunch. You know, everything I eat lately seems to bother me.
Does your stomach ache?
I feel a bit nauseated, but, mostly just a tightness in my chest.
Marcia, did you say tightness in your chest?
Well, it doesn't hurt. It just feels tight, kind of like a squeeze. I'll be fine, really. It's nothing.
Marcia, why don't you sit down? Let me help you sit down here. Have a seat. Have a seat.
Oh, that shoots nothing. Wait.
Marcia, I'm medically trained. May I check your pulse?
Oh, Stella, don't be silly. I'm fine, really.
Maybe so, but I'm concerned. May I? It'll only take a minute.
Well, okay, but really, this is silly. It's nothing.
Okay.
Well, Dr. Stella, what's your diagnosis?
Marcia, I'm not a doctor, but I have had medic first aid training. May I check your temperature?
Sure.
Do this with your lip, Marcia.
What was that for?
I was just checking your tissue color. And this tightness in your chest, how long have you had it?
About a half an hour.
I noticed you're wearing a medic alert tag.
Oh, that's for my diabetes. I take insulin. You knew that. But Stella, there is no need to worry. It's just something I ate, and this happens a lot lately.
Marcia, maybe so, but I'm concerned. Your pulse feels fast to me, and you're cool and sweaty, and this tightness in your chest concerns me. Let's just call the paramedics and let them check you out.
Stella, please, I don't want to frighten anyone, especially not my husband, and I certainly don't want to bother the paramedics for such a silly thing.
Marcia, your husband doesn't even need to know right now. That's what we have the paramedics for. Let's just have them check you out. Linda, could you please ask the receptionist to call the paramedics? Marcia's not feeling well. Tell them someone will meet him at the front door.
Sure, Stella. I'll go meet him and bring him up.
Thanks, Linda. Marcia, would you like to lie down?
Oh, no, I'd feel better just sitting right here.
Okay, then I'll stay here with you until the paramedics get here.
Asthma is a condition in which the lower airways are overly sensitive and reactive. The airways constrict, reducing the flow of oxygen to the bloodstream. Thousands of people die from asthma every year. Asthma can be an immune response similar to an allergic reaction. It can be a reflex spasm of the bronchi due to direct irritation from inhaled substances such as smoke. It can be brought on by respiratory infection or emotional stress. It can be triggered by exposure to cold air or rapid changes in air temperature. Exercise may also trigger asthma. 3 major things happen during an asthma attack. The airways constrict, the interior lining swells, and a thick, sticky mucus is secreted. All of these combine to reduce the size of the air passages and restrict the flow of oxygen to the bloodstream. Signs and symptoms include labored breathing with long expiration times, wheezing on expiration, a persistent high irritative cough, weakness, sweating, restlessness, anxiety, and poor tissue color. The patient may sit leaning forward with his shoulders hunched and his hands braced on a bed, a chair, or his knees. It will require a great deal of effort for him to breathe. In serious cases, the mucus may be thick and the constriction so great that wheezing sounds become inaudible. The patient may appear very weak and often becomes exhausted from the effort needed to breathe. The patient may be extremely anxious and frightened. He may have difficulty speaking or answering your questions due to exhaustion. A medic alert tag may assist you in determining the possible cause of his breathing difficulty. He may take various medications which are designed to reduce inflammation, relax the bronchi, or reduce sensitivity of the airways. You may assist the patient in taking the appropriate medication which has been prescribed for him. Monitor his response to the medication. Reassure him that you will take care of him. There may be limits on the amount of medication he can take without serious side effects, such as cardiac arrest. It is important to activate EMS when the patient is experiencing breathing difficulty with no history of asthma, or when a person known to have asthma does not respond normally to his medication. Closely monitor his breathing, circulation, and tissue color. Reassure him that help is on the way. When the paramedics arrive, pass on any information you have on his medical history and medications that have been given. Your prompt action will increase the comfort level of the patient and the quality of care he receives. A poison is any substance that can cause illness or death. Drugs, household chemical products, certain plants, and toxic gases and fumes are examples of potential poisons. Children are often the victims of poisoning. Curiosity, inability to read labels, easy access to drugs and cleaning products, and lack of understanding contribute to childhood poisoning. Poisoning deaths for children have decreased since 1960. However, poisoning deaths in teenagers and adults have increased, primarily due to drug abuse. A victim of poisoning may have one or more of the following signs and symptoms: nausea, stomach pain, drowsiness or loss of consciousness, burns around the mouth or on the hands, seizures, and difficult or shallow breathing. Open containers or other visible signs of poisoning may be evident. If you suspect that a responsive person has been poisoned, immediately call the Poison Control Center. They will instruct you in the proper steps to take. Try to have the container or substance available to help determine the amount and type of substance ingested. Do not induce vomiting unless told to do so by the Poison Control Center. If the patient does vomit, save the vomitus for the doctor. If a suspected victim of poisoning is found unresponsive or becomes unresponsive, assess the airway, breathing and circulation, and activate the emergency medical service system. Monitor and care for the patient until help arrives. The best treatment for poisoning is prevention. Your Poison Control Center can help supply information on poison-proofing your home and garage. Various stickers have been designed to mark harmful substances. These stickers are supposed to act as a visual warning to children not to play with poisons. Unfortunately, children are sometimes attracted to the colorful stickers. Having the children help mark the poisons may increase their understanding and reduce the risk of poisoning. It is important not to depend on stickers alone to deter your children. In addition, store potentially harmful substances out of the children's reach or use locks on cupboard doors. Do not transfer substances from their original containers. Have syrup of Ipecac available so you can induce vomiting if directed to do so by your Poison Control Center. Teach children that medicine and pills such as vitamins are not candy and take medications only in prescribed dosages. Include the Poison Control Center number on your home emergency plan and train all members of your family, including babysitters, how to call for help. Another type of poisoning can occur upon exposure to gases or fumes. This may occur in a confined space, such as a well or sewer, or from accidental exposure in the workplace. Exposure to such poisons can cause loss of consciousness and respiratory arrest in a matter of seconds. Remember setup. As a rescuer, you must first assure your own safety and the safety of those in the immediate area before attempting a rescue. An emergency response plan and trained personnel should be available in each facility which deals with hazardous materials. Too often, would-be rescuers become victims because they don't recognize the hazard or take the time to see that the scene is safe before entering. Proper training and regular practice will help you to recognize hazards and respond safely. If you are equipped to safely rescue the patient, have a bystander activate EMS while you perform your rescue. If you are not equipped, you will need to activate EMS and wait for help. See that the patient is removed to a safe, well-ventilated location. A trained rescuer can then begin primary assessment. Her assessment shows that the patient is not breathing, so she inserts a barrier and gives 2 slow, full rescue breaths. She then checks the pulse. The pulse is present, so she resumes rescue breathing, giving 1 breath every 5 seconds. She continues her circle of care for the patient until the EMS providers arrive. The cells of the human body depend on a balanced supply of oxygen and nutrients to function properly. Sugar is an essential nutrient which the body uses as a source of energy. Insulin, a hormone produced in the body, is necessary for the transfer of sugar from the bloodstream into the body cells. Diabetes is a condition in which the body does not produce enough insulin or is not able to effectively use that insulin which is produced. Some diabetics control their condition through diet alone. Others use pills or daily injections of insulin. When an imbalance occurs between sugar and insulin, a diabetic emergency can develop. The 2 types of diabetic emergencies are diabetic coma, meaning excessively high blood sugar, and insulin shock, meaning excessively low blood sugar. High blood sugar occurs when there is not enough usable insulin to transfer the sugar into the body cells. This may happen when a diabetic is not receiving treatment, does not take insulin as prescribed, or when poorly controlled diabetes is complicated by infection or other illness. Early signs of excessively high blood sugar are extreme thirst and frequent urination. If this condition is not corrected, the person may become restless, confused, and irritable and may even appear to be drunk. The signs of high blood sugar develop slowly over a period of hours or days. As the condition worsens, the person will gradually lapse into a coma. The signs of high blood sugar include rapid, deep, sighing respirations, warm and very dry skin, rapid, weak pulse, and a sweet, fruity odor on the breath similar to the smell of cheap wine. A person with excessively high blood sugar needs to be transported immediately to the nearest hospital for evaluation and treatment. Activate EMS and provide basic life support until additional help arrives. Insulin shock, excessively low blood sugar, occurs when there is not enough sugar in the bloodstream. This can develop when a diabetic takes too much insulin, does not eat, is late for a meal, or overexercises. What little sugar there is gets quickly transported into the body cells. This severely limits the amount of sugar available to the brain. The brain can be very sensitive to this lack of sugar. Excessively low blood sugar, if not treated promptly, can lead to unconsciousness and can result in brain damage. The signs and symptoms of low blood sugar can develop quickly over a matter of minutes. The person may feel dizzy, have a headache, and may be disoriented, confused, or exhibit aggressive or unusual behavior. She will have pale tissue color and moist, clammy skin. The pulse is rapid and full. Respirations are normal or shallow. A medical alert tag or information from family or friends may aid in determining the problem. Since low blood sugar causes confusion, the patient is often not a reliable source of information. Because loss of consciousness and brain damage can occur quickly, it is vital that the person with low blood sugar receive sugar immediately. If the person is responsive and able to manage her airway, give her glucose tablets, glucose gel, sweet fruit juice, candy, or other sweet substances. Some diabetics will carry glucose tablets, gel, or candy to use in case of low blood sugar. Do not be afraid to give too much sugar. A glass of sweet fruit juice or a whole candy bar may be necessary to correct the problem. If she becomes or is found unresponsive, activate the EMS system. In the past, it has been recommended that glucose gel or other sweet substances be placed under the tongue. Recent studies have shown this to be ineffective. These patients need intravenous sugar. Place the patient in the recovery position. Continue to monitor and care for the patient until help arrives. If you are not sure whether a person has excessively high blood sugar or excessively low blood sugar, it is best to give sugar. Giving sugar to a person with high blood sugar will not make the condition much worse. However, giving sugar to persons with low blood sugar may dramatically improve their condition and may prevent brain damage. Insulin is not an emergency medication. There is never a time when you would give insulin, regardless of circumstances or statements from the patient. The human brain is the master control center for all body functions. Messages are sent out from the brain cells via electrical impulses. These messages allow us to perform simple or complex tasks. An interruption of the normal electrical activity in the brain can momentarily interfere with normal functions of the body. Epilepsy is a condition in which abnormal discharges of electrical activity occur in the brain. Epilepsy can afflict anyone at any time. Head injuries are a common cause of epilepsy. When abnormal discharges of electrical activity occur in the brain, the person will experience a seizure. Seizures take many forms. The person may simply stare for a matter of seconds and then resume his activity as though nothing happened. The person may have facial twitching or unusual eye movement. Or the person may display behavior which seems inappropriate and purposeless, such as picking at his clothing or walking about aimlessly. His movements are generally repetitious and inappropriate for the situation. Some seizures will affect the whole body, taking the form of violent jerking motions. The type of seizure will vary depending on the portion of the brain affected. Most epileptics achieve some degree of control over the seizures through use of medication. However, you may have occasion to aid a person who experiences a seizure. For seizures in which the person has a glassy stare, picks at his clothing, or walks about aimlessly, protect him from injury. You may need to gently direct his movements away from danger. Do not agitate or try to restrain him. Stay with him until he becomes alert and oriented. Some seizures will be preceded by an aura during which the person may experience odd sounds, an unpleasant odor, or unusual colors. This serves as a warning that a seizure is going to occur. If this happens, you can help the person into a lying position. However, there may be no warning and the person may stiffen and fall to the ground. In all cases, protect the patient during the seizure. See that the head and limbs are protected. Talk to the patient and reassure her that you will take care of her. Do not restrain her. Do not place anything in her mouth, including your fingers. Clear the area of hard or sharp objects. During the seizure, the person will make convulsive jerking movements of the whole body. The jaw muscles may go into spasm. Contraction of the chest muscles during the seizure may cause the patient to appear to have an airway obstruction as they become bluish in the face and lips. Lack of normal breathing during a seizure is rarely a problem. The seizure activity may last for several minutes. Loss of bowel or bladder control is common. When the seizure activity subsides, the patient will be at a lower conscious level. Continue to talk to the patient and reassure her. Place her in the recovery position to keep the airway open and allow fluids to drain. Check for any injuries that may have occurred during the seizure. Oftentimes, epileptics will want to sleep following a seizure. Encourage them to at least rest. Patients with a history of epilepsy rarely require transportation to a hospital. The cases in which the EMS system should be activated are if the seizure lasts more than 10 minutes in a known seizure patient, the patient has repeated seizures without regaining consciousness, the patient has no history of seizures, if the patient is injured, or the patient requests emergency care. Seizures can occur for reasons other than epilepsy, such as drug overdose. However, the treatment is the same. Protect the person from injury during the seizure. Following the seizure, perform the indicated emergency care. Activate the emergency medical service system as required.
Each year, millions of people are involved in accidents. The accidents may be minor, or they may be potentially deadly or disabling. As a trained rescuer, you can help accident victims by understanding and following your priorities of care. Mishandling of an injured patient can turn a simple fracture into a lifetime of paralysis. We have been led to believe most cars explode after a collision. In fact, the risk of a vehicle fire is only 1/2%. Instead of racing up and pulling people out of cars, you will learn a systematic method of checking them in position before they are moved. Remember, accident scenes can be very dangerous. The first priority is your own safety. Consider setup and proceed to help only if it is safe to do so. Remain alert to hazards such as moving traffic while you are caring for the patient. People involved in accidents may have several injuries. Some injuries may be obvious, such as an open wound. What may not be obvious are more serious injuries, such as a neck injury. In order to identify all injuries and protect the patient from further harm, you will perform injury assessment. Injury assessment is performed following primary assessment. Primary assessment, the check for life-threatening conditions, may be performed as you approach the patient. Is the patient responsive? Airway open? Breathing and circulation adequate? Any serious bleeding? If the patient is unresponsive, activate EMS and continue with your primary assessment and circle of care. If the patient is responsive, you may perform your secondary assessment. This patient is responsive, talking, and not seriously bleeding. The scene presents no serious or immediate threat. Let the patient know that you are trained and you will take care of him. Touch is an important medical communication. By placing one hand on the shoulder, you may help establish a more positive communication. Ask the patient not to move. Explain to the patient what you are going to do. It is important that the patient not move his head and neck during the assessment, as you do not want to aggravate possible spinal injuries. In urban or suburban areas where EMS response time is within 15 minutes, you may wish to simply maintain the patient's head in position. Continue to monitor the patient and wait for EMS to check the patient for additional injuries. If EMS is delayed and a second rescuer is available to hold the head in position, you may proceed. The head-to-toe check is done in the position in which you find the patient. You will begin at the neck and systematically palpate the body, checking for pain, deformity, or fluid which may indicate injury. To palpate is to examine by touch. Use a steady, gentle, but firm pressure while sliding along the bony structures of the body. Take care not to cut yourself on sharp objects during the assessment. Communicate with the patient. Let him know what you are going to do. Ask him to respond if he feels pain or discomfort. Begin by checking the neck. Place one hand on the head to keep the head and neck still. With the fingers of the other hand, feel the neck or cervical spine. Ask the patient to respond if he feels pain or discomfort. If there is pain or discomfort in the neck, stop the assessment and maintain the head and neck in position until help arrives. If there is no pain or discomfort in the neck, continue your assessment. Feel the skull with your fingers and hands. Pain, deformity, or moisture may indicate injury. Look at the eyes. Do the eyes move together? Can the patient see clearly? Look in the ears for blood or clear fluid. Either or both of these indicate possible head injury. Do not stop the flow of this blood or fluid. Place a hand under each shoulder blade. Use your fingers to push forward to check the shoulder blades for pain. Surround each shoulder with a hand and squeeze. A hollow spot, deformity, or pain may indicate injury. Place a finger on each side of the collarbone. Slide your fingers down the collarbone, checking for pain or deformity. Repeat this on the other collarbone. To check the arms, place one hand on the upper arm and with the other hand slide firmly down the bones of the arm. Repeat this on the other arm. If there is no injury to the neck or arms, ask the patient if he can wiggle his fingers and move his hands. Place a hand on each side of the rib cage and gently press inward once. Any pain may indicate injury to the ribs or chest. Gently press once on each side of the abdomen. The injured abdomen may feel board-like or be tender to the touch. To check the back or spine, place one hand between the shoulder blades on the upper spine. Slide the other hand under the small of the back so the fingers can reach the lower spine. Gently move your fingers towards each other along the spine as far as you can without moving the patient. Stop this check at any time the patient complains of pain or discomfort. Place one hand on each side of the pelvis. Squeeze together to check for pain. To check the legs, place one hand on the upper thigh and with the other hand firmly slide down the leg. Check the other leg. Ask if he can wiggle his toes. During injury assessment, maintain communication with the patient. This will aid in your assessment and ensure that the airway is open and breathing and circulation are occurring. The value of injury assessment is that it allows for identification of non-obvious injuries that could be serious, disabling, and potentially fatal. It protects the patient from further harm. It lets the patient feel cared for, and it allows you to identify and care for injuries as well as know whether the patient should be moved or immobilized. These actions may prevent mishandling of an injury, which could have resulted in paralysis or death. The bones and joints form a unique framework for the body that provides shape, stability, and protection, and allows for movement. When nature's framework is injured from fracture or dislocation, a substitute for stability and protection must be provided. A fracture is a break in a bone. A fracture may be closed, where the bone ends have not broken through the skin. Or a fracture may be open, where the broken bone ends lacerate the skin, causing a wound. A puncture wound may cause an open fracture. A dislocation occurs when the bone ends that form a joint become separated, allowing a space or hollow spot where a space or hollow spot does not normally exist. Fractures and dislocations may be recognized by the signs and symptoms. A closed fracture upon evaluation may have localized pain, point tenderness, deformity, and swelling. An open fracture may have localized pain, point tenderness, deformity, swelling, and a wound at the fracture site. The bone ends may or may not be visible. Signs and symptoms of a dislocation include deformity of the joint, extreme pain, and loss of function and movement. If allowed to go untreated, a fracture or dislocation may cause additional damage from tearing of tissues, nerves, and blood vessels. Damage due to lack of circulation and a lack of sensation due to nerve blockage may also occur. The priorities of care for fractures and dislocations are to prevent further damage from improper movement or from swelling. When a fracture or dislocation occurs, splinting provides the protection and stability that the body can no longer provide. If EMS is responding, you may just keep the fracture in position and let the EMS providers do the splinting. If EMS is not available and you do the splinting, splint the fracture or dislocation in the position in which it was found. Do not move or straighten it. Splinting provides stability and protection by immobilizing the fracture site or dislocation, as well as the adjacent and following joints of an extremity. As a result, damage to tissue, nerves, and blood vessels is minimized. Preventing movement by splinting can significantly reduce pain. An ice pack or bag of ice wrapped in a cloth may be placed on a closed fracture or dislocation to help prevent swelling and minimize pain. Many materials may be used for splinting. Padded boards, rolled blankets, cardboard, newspapers, magazines, and pillows are all suitable. Splints may be held in place with tape, cravat bandages, or improvised materials. Have all your materials ready and at hand before starting the splinting procedure. Use 2 people. Work slowly and gently. Splints must be long enough to immobilize the joints above and below the fracture or dislocation, and rigid enough to provide the necessary stability and support. The broken bone ends and adjacent joints are supported while the splint is placed in position. Pad the splint generously so that when secured in place, steady firm pressure will be applied to the entire length of the limb. Carefully secure the splint in place. After splinting, continue to monitor the patient's extremity below the fracture site or point of dislocation, checking for adequate circulation and sensation. If circulation and/or sensation decreases or becomes absent, gently loosen the splint only enough to regain circulation and sensation. Continue to monitor and adjust as necessary. A fracture with deformity or dislocation is left exactly in the position found and splinted in that position. To splint in position, use a solid base under the entire injured extremity. Lift the injury by placing a hand above and one below the injury site. Pad the splint generously to match the deformity of the limb. When tied and taped in position, the splint should keep the deformity as you found it and help relieve pain for the patient. An ice pack may help prevent swelling. Continue to monitor and care for the patient while arrangements are made for additional medical care. The central nervous system is made up of the brain and spinal cord. The peripheral nervous system relays messages between the brain and the entire body. Functions and actions of the body are controlled through the nerves, spine, and brain. The brain is protected by a thick, nearly uninterrupted circumference of bone called the skull. A special fluid floats around the brain and spinal cord, acting as a shock absorber. Head injury may include damage to the scalp, skull, and brain. Common causes or mechanisms of injury to the head: motor vehicle accidents, direct blows, falls, assaults, and injuries during sporting events should alert you to the possibility of head or brain injury. A blow to the head or sudden deceleration, as when the head hits the ground or a car windshield, can fracture the skull, tear blood vessels, and bruise the brain. These injuries can allow bleeding and swelling inside the skull and cause abnormal pressure on the brain. This abnormal pressure on the brain may force the protective clear fluid and blood to drain from the nose and inner ears. With all serious head injuries, suspect neck injuries and treat the head, neck, and body as one unit by carefully immobilizing the head. Do not stop bleeding from the nose or ears. Your injury assessment may reveal some or all of the following signs and symptoms of head injury: open wound of the scalp, deformity of the skull, blood and clear fluid draining from the nose and ears. There may be nausea and vomiting and bruising under the eyes and behind the ears. The patient may have an altered conscious level with shallow or irregular breathing. The pupils may be unequal in size. If you suspect a head injury, assure the airway, breathing, and circulation. Any change in the level of responsiveness is extremely important. Pass this information on to the EMS providers. Maintain body temperature and monitor the level of responsiveness. Continue to reassure the patient and perform your circle of care until additional help arrives.
All messages to and from the brain must flow through the spinal cord. The bony structure of the spine protects this sensitive cord. Fracture, dislocation, or compression of the spine may cause pressure on the cord with bruising, swelling, and an interruption in the flow of impulses to and from the brain. Accidents which may cause spinal injury include automobile, bicycle and motorcycle accidents, diving or sledding accidents, falls, compression injuries, bullet wounds, and any significant blow to the head. In trauma cases, it is safest to assume the patient has injured his or her spine. Do not move the patient. Continue to protect and care for the patient until help arrives. Additional injury, even paralysis, may occur if the patient is moved improperly. Do not move the patient. During injury assessment, if you find pain in the head, neck, or back, stop the assessment and maintain the head, neck, and back as one unit. If the EMS provider will be delayed, you have a second rescuer available, and you need further evidence of spinal injury, you may do additional checking. Ask the patient if he can feel your touch. Can he feel you pinching his hands? Ask the patient to squeeze your hands and wiggle his fingers. Now check the legs. Can the patient feel your touch? Can he wiggle his toes? Inability to move upon command may indicate injury to the spinal cord. If the patient has pain, numbness, tingling, or inability to move upon command, you have additional reasons to keep the patient from moving. Monitor the ABCs and maintain body temperature. Talk to the patient and reassure him that you will take care of him. Do not allow movement of the patient until he can be properly immobilized on a stretcher or frame to protect the head, neck, and spine from movement. An ill or injured patient may need to be moved. Protecting the body from further harm is necessary. The bony structures of the body can assist you in protecting the patient and minimizing the risk of further harm. Just as the skeleton is supported and kept straight without further injury, you can lift and move the body by using arms to replace the supports in the picture. The priority is to treat the head, neck, and body as one unit. Maintain the spinal cord and column in the alignment in which it was found. To do this, hold the neck in line with the body to prevent movement. Use the shoulder and pelvic structures to support the spine and prevent movement. Support the knees and the legs below the knees. As you can see by following this concept of protecting the body, you can use 3, 5, or even 7 rescuers to do the lifting, and the body will be kept straight and well protected. In this case, we are using 3 people to do the lifting. The patient has no pain or discomfort in the neck or back, so one person cradles the head and neck. The other people place their arms under the patient at equal intervals using the shoulder, pelvic, and lower leg structures to assist in keeping the patient flat. This helps prevent unnecessary movement. They lift on command and keep the patient in the same position in which he was found. An ill patient may need to be moved. This lift is for people who do not have injuries. Use the body's own structure to protect the patient and help you lift. One rescuer lifts the wrists as the other rescuer slides his arms under the patient's arms. He grasps opposite wrists and pulls the arms into the abdomen. The second rescuer slides one arm under both legs just above the knees. Now the patient can be lifted and carried gently and safely. Lifting and movement of a patient are only used when EMS is not available or greatly delayed. By understanding and using the supporting structures of the human body, an ill or injured person may be lifted and moved with minimal risk of further injury or discomfort. A wound is a traumatic break in the skin that allows body fluids to escape and poisons, viruses, and bacteria to enter. Wounds may be simple, such as cuts or scrapes. They may be punctures from sharp objects. They may be tearing injuries, such as bites from animals or humans. They may be serious, complicated wounds caused by knives or guns. Such wounds may involve damage to underlying tissues, nerves, blood vessels, and organs. Or they may be spider or snake bites. Damage from wounds may be clearly visible. Or in some cases it may be hidden, such as when an impaled object remains embedded in a wound. Your priority in wound care is the same as all patient care: setup and your circle of care. Begin with setup. Assure the scene is safe to enter. Such hazards as snakes and spiders, uncontrolled animals or humans, flying bullets, sharp metal or glass, and blood and body fluids at the scene are all potential hazards. Once you have assured the airway, breathing, and circulation, you will direct your care toward preventing blood loss and minimizing contamination. Protect yourself and the patient from further harm. Use your barriers. Clean dressings may be applied and bandaged in place. Some wounds may require follow-up care. Wounds which are long, deep, have gaping edges, or are on the face or over a joint may require stitches to heal cleanly. Tetanus shots are generally recommended every 5 years. Observe the appropriate procedures for disposal of contaminated waste and follow-up regarding bloodborne pathogens. In many cases, minor wounds can be cared for by thorough cleaning with antimicrobial soap and water. The patient may be able to do this on her own. You may help assure that contamination of environmental surfaces does not occur. Spider and snake bites may be washed with soap and water, and medical aid sought for appropriate care. Depending on the amount and type of venom injected, you may need to provide basic life support for the patient. Your reference manual provides additional information on these special cases. In cases of amputation, control bleeding and wrap the body part in a cool, moist dressing for transportation to the hospital for reattachment. Impaled objects are bandaged in place and further care sought for evaluation and treatment. Bullet or stab wounds may cause significant internal and external damage. Activate EMS and continue your circle of care for the patient until additional help arrives. The materials used in bandaging are the dressings which cover the wound and the bandage which holds the dressing in place. The fibers of a dressing are designed to help catch the blood and aid in the clotting process. Dressings come in a variety of sizes and thicknesses. They should be sterile or clean and be of a material that will not leave residue in the wound. Dressings can be held in place with stretch roller gauze such as this, a triangular bandage, a cravat, or tape. Stretch roller gauze is recommended for bandaging since it conforms to the body and clings to itself. Stretch gauze has made complicated bandaging techniques unnecessary. Triangular bandages can serve many purposes. They can be used as slings. They can be folded and used to hold a dressing in place. Or they can be used to tie a splint in place. The principles of bandaging are: a bandage should be tight enough to prevent slipping, but not so tight as to impair circulation. Leave fingers and toes exposed if uninjured to watch for swelling or changes of color which may indicate impaired circulation. Loosen bandages immediately if the patient complains of numbness or a tingling sensation. Once a dressing is in place, do not remove it. If blood soaks through the dressing, bandage another on top of it. The care that you provide for wounds will help control bleeding, protect the wound from further damage, and prevent further contamination. The eye superbly outperforms the most expensive automatic camera and may last a lifetime and even longer. Injuries to this unique organ can affect its ability to perform and for this reason need special care. When there is a laceration or burn to the eyeball or surrounding tissue, penetrating objects in the eye, or the eyeball has been exploded from the socket, you may use a special bandaging technique. Since serious damage to the eyes may be accompanied by head, spinal, and other injuries, respect your priorities of care before bandaging the eyes. If there are no other injuries that are more serious, begin bandaging by placing a cut-out 4x4 over the injured eye. Prepare another dressing with a larger hole and slide it over a dry, clean cup. Place the cup over the eye. Have the patient close the other eye and cover it with a 4x4 dressing. Since both eyes move together, both need to be covered to protect the affected globe from additional injury caused by movement. While the patient holds the dressings, the rescuer gently bandages the cup and dressings in place. The cup protects the eye from further injury and from drying out. This same procedure is used any time there is a laceration to the eyeball, to surrounding tissue, or a penetrating object in the eye. Since you have taken away the sight of the patient, you need to be the patient's eyes. Stay with the patient. Put a hand on her shoulder. Let her know you are near and reassure her. Verify that arrangements have been made for additional medical aid. Chemicals can cause burning to the eyeball and surrounding tissue. A person who receives a chemical burn of the eye should go directly to the closest water or eye wash station and flush the affected eye with copious amounts of water. Hold the eyelids open with your fingers during flushing. If only one eye has been affected, avoid flushing chemical into the non-affected eye. If the patient has contact lenses, he may need to pause and remove the lenses to assure complete flushing of the eye. Strong acids or alkaline solutions can penetrate deeply into the eye and cause permanent damage. Immediate, prolonged, and continuous flushing is recommended. You can never use too much water. Activate your in-house emergency plan and continue to flush until EMS arrives. If emergency service is not provided in your area and you must transport the patient to the nearest emergency medical facility, continue flushing with clean water by whatever means are available.
The human body is designed for warm, tropical climates. In order to live in colder climates, we must create effective shelters, such as houses, cars, and special clothing to protect us from the cold. When we are unprepared for exposure to cold, we may develop a condition known as hypothermia, a dangerously low body temperature, and we may also experience frostbite, a freezing of body tissues. Hypothermia, the general cooling of the body, occurs in stages. In the early stages, the body shivers in an attempt to generate heat. If this does not produce enough heat, the body will shift blood to the core to protect vital organs. As this occurs, the person's muscles will not work as well. They will lose coordination and may stumble and fall. They will become disoriented and confused and may mumble incoherently. They may do irrational things like take off clothing. Water draws heat from the body 25 times faster than still air at the same temperature. Wet clothing or immersion in cold water will greatly speed up the heat loss. Wind also speeds up heat loss. If the person is not cared for properly, he may become unresponsive and die. Frostbite, the freezing of the body tissues, may occur together with or independently of hypothermia. Regardless, it can be a serious medical problem and requires special treatment. Frostbite occurs when the fluid within the body's cells leaks out and freezes between the cells. Ice crystals form and the cells are not able to function. There are several degrees of frostbite. The least serious is frost nip or superficial frostbite. This normally affects the tips of the ears, nose, cheeks, chin, fingers, and toes. There may be a tingling, slight pain, or no pain as it develops, and for this reason may go unnoticed. It is important to watch your companions for signs of frost nip. Frost nip is characterized by gray or yellowish patches of skin. If you suspect frost nip, do not rub the affected area. Direct pressure on the area with a warm body part or placing the fingers in the armpit will usually be adequate for rewarming. Deep frostbite is a more serious condition. It most commonly affects the hands and feet. These are areas which are the last in priority to receive warm blood from the body core. The tissues will appear pale, cold, and solid. If a person with frostbite must walk on the affected part in order to reach medical help, the affected part should remain frozen until it can be cared for properly. Once a body part is partially or totally thawed, the person should not walk on it or use it. This condition can be extremely painful. If you come across people who appear to be suffering from hypothermia or frostbite, care for them gently. Their greatest risk is continued heat loss and improper treatment. After performing a primary assessment, gently move the patients out of the wind and cold. Use the best shelter which is most readily available. Gently cover the head and neck to prevent further heat loss. Talk to the patients and reassure them that you will take care of them. Remove wet clothing and gently pat the skin dry. Complications such as cardiac arrest can develop, so treat the patient gently and avoid rough or jarring treatment. Check for signs of frostbite. Do not allow frostbitten areas to be exposed to direct heat, such as a car heater. If EMS is not available, you may need to carefully transport to the nearest evacuation point or medical facility. During transport, continue to monitor the patients using your circle of care. Provide care as needed. Your best protection against exposure to cold is prevention, early recognition of signs and symptoms, and proper treatment. Know the hazards you face and be prepared to deal with them. The human body is designed to adapt to certain changes in the environment. In a warm or hot environment, we sweat to rid our bodies of excess heat. In order for the body to function efficiently in a warm or hot environment, it must be able to adjust to the increased temperature. Some people adjust readily to increased temperatures, while others do not. When the body does not adjust readily to increased temperatures, medical problems ranging from minor to life-threatening may develop. Two problems associated with exposure to heat are heat exhaustion and heat stroke. Heat exhaustion, a serious problem, is actually a mild form of shock caused by poor distribution of blood in the body. The blood serves many functions in the body. One of the functions of blood is to carry heat from the interior of the body to the skin. The heat is then carried away from the skin by the evaporation of sweat. Another function of blood is to supply the muscles and body organs with oxygen. A person working in a warm environment places a demand upon the circulatory system to cool the body as well as deliver oxygen to the body tissues. Heat exhaustion occurs when the system is not able to perform these functions adequately. Carefully move the patient to a cool location. Signs and symptoms of heat exhaustion include pale tissue color, moist, clammy skin, profuse sweating, rapid, shallow breathing, and a weak pulse. Weakness, dizziness, and headache are common. A person in heat exhaustion is treated as for shock. Have the person rest in a cool location, but do not allow him to become chilled. If the person does not respond promptly to rest in a cool location, transportation to the appropriate medical facility should be arranged. Heat exhaustion may be avoided by adequate intake of fluids and careful monitoring of the body during physical exercise in a warm environment. Periods of rest in a cool location may be helpful. The symptoms of heat exhaustion often precede heat stroke. If not treated, heat exhaustion can lead to heat stroke. Heat stroke is a true life-threatening condition. It occurs when the body's thermostat fails. The body generates more heat than it can dissipate. Heat stroke is a common occurrence during the summer months when there are days or weeks of temperatures in excess of 100 degrees Fahrenheit. Humid weather contributes to heat stroke by reducing the evaporation of sweat, which normally carries away body heat. Those most commonly affected are the sick, the elderly, infants, and children who have difficulty tolerating extreme temperatures. Heat stroke, if not treated rapidly, can cause damage to the brain and nervous system and even death. A person experiencing heat stroke will be disoriented and confused. The skin will be very hot. In most cases, perspiration will be absent. However, some highly trained athletes may continue to sweat during heat stroke. As his temperature continues to rise, he may become unresponsive. A person experiencing heat stroke must be cooled immediately. While assuring adequate breathing and circulation, place the person in a cold bath, hose him down, or use continuous cold applications to reduce body heat. Recovery from heat stroke depends on the speed of treatment. Reduce the body temperature by whatever means are available. While you work on the patient, send another person to notify the nearest emergency medical service provider. In true heat stroke cases, it may take as long as 45 minutes to lower the body temperature to near normal. Continue to cool the patient and monitor him carefully. If you're in a remote area and have a thermometer, it may be important to monitor the core temperature to assure that the patient is not overcooled. Continue to monitor and care for the patient until additional medical care arrives. Persons who experience heat stroke frequently have complications, and emergency care should be obtained as soon as possible. Skin, the largest organ of the body, performs many vital functions. It protects the body from bacteria. It aids in regulating body temperature. It protects against loss of body fluids, and through its many nerve endings, furnishes the brain with information about the external environment. Burns of the skin can reduce its ability to perform these vital functions. Burns are most commonly caused by heat from sources such as fire, hot water, or steam. Chemicals are also a common cause of burns. As in all emergency situations, you may be faced with problems in addition to the burned patient. Fire, live electrical wires, or toxic gases may be present. Think setup. Consider your limitations. Protect yourself first. Treatment for burns must follow the same priorities as treatment for any other injury. Perform your primary assessment and care, then protect the burned areas from further damage, fluid loss, and further contamination. The severity of burns is determined by the depth of the burn and the percentage of body surface affected. Also, burns in critical areas such as the hands, feet, face, and genitalia are more serious. Partial thickness burns affect the epidermis or outer layer of skin. The area will be tender and painful and will appear red in lightly pigmented people. They may also penetrate through the epidermis and will have blistering and pain. A full thickness burn causes damage through the skin and into the underlying tissues. The burned area may appear charred, white, or grayish in color. A full thickness burn will not hurt as nerve endings have been destroyed. However, surrounding areas of partial thickness burns may be painful. Partial thickness burns in which the skin is not broken are treated by immediately cooling the affected area with cool water to remove the heat. Sterile or clean dressings are used to aid in preventing further contamination and fluid loss. In applying the dressings, take care not to break blisters. Use dressings made of a material that will not leave a residue in the burn. The dressings are applied in such a way that the burned areas do not come in contact with each other. The dressings are bandaged lightly in place since swelling may occur. Additional medical aid should be obtained as needed. Exposure to smoke and hot gases and burns affecting the face and neck are serious as they may indicate injury to the breathing passages. Special care must be taken to assure that the airway is open and breathing adequate. The pulse is checked to ensure that the heart is beating. Full thickness burns are then covered with a clean, dry dressing or a special burn dressing such as this. It is important to avoid cooling large areas of the body as the skin cannot regulate body temperature and hypothermia may occur. Continue to perform your circle of care while arrangements are made for transportation to an emergency medical facility. Chemical burns can cause extensive damage to the skin and underlying tissues and must be cared for immediately. When a chemical burn occurs, immediately flush the burned area with a steady stream of water. Flush the affected area for a minimum of 15 to 20 minutes. The EMS system should be activated while flushing is going on. Continue flushing the affected area until EMS arrives. If clothing has been contaminated, it should be cut away or removed. In doing so, avoid getting chemical on body parts that were not initially affected. Continue flushing as indicated and seek additional medical aid. An electrical accident may happen anywhere electricity is found. Even common household current can be deadly. Electricity is predictable. It must have a beginning and an ending place, a source and a ground return. Accidents involving electricity take place between these 2 points. When an object or person contacts an electrical source, it allows the current to reach ground with more ease than through its normally planned path. The human body is a conductor of electricity. 2 pathways through the human body that electrical current will commonly follow are the blood vessels and muscles. The body is more conductive when it's wet. Kneeling in wet grass, such as this, increases your risk of electrocution. Your first priority as a rescuer in any electrical accident is to protect yourself from being electrocuted by the same source as the patient. the rescuer must assure that the electrical source has been disconnected or cut off before attempting either rescue or emergency care. Downed power lines, such as this one, may appear harmless, but the entire car may be electrically energized. Wires or surfaces in contact with wires should not be touched unless the rescuer is trained and equipped to handle such an emergency. If your car is in contact with a downed wire, it is usually safest to stay in the car until you are rescued by professionals. The power companies have skilled personnel that are trained and equipped to handle these emergencies. These skilled people should be called before any rescue action is attempted. The passage of electrical current through the human body can cause a variety of medical problems. These problems fall into three major categories: respiratory or cardiac arrest, electrical burns, and fractures. One or all of these conditions may be present following contact with electricity. Respiratory or cardiac arrest may occur in any electrical accident, especially those with voltages from 50 to 500 volts. Electrical burns occur when the current passing through the body cooks the tissues. In some cases, there will be extensive surface damage, while in others, there may be little surface damage. However, there may be extensive damage to underlying tissue, nerves, and blood vessels. Fractures associated with electrical accidents usually result from a violent contraction of the muscles or from a fall. If you witness or come upon a person who has received an electrical shock, cut off the power source and call out for help. Tap him on the shoulder and shout, "Are you okay?" If he does not respond, activate the EMS system. Assure that the airway is opened and breathing and circulation are adequate. If the patient is in respiratory or cardiac arrest, rescue breathing or CPR should be performed as indicated. If the patient is responsive and EMS is delayed, you may perform injury assessment to identify injuries such as fractures. A careful check for electrical burns is also made at this time. Exit wounds are often hidden. The exiting current may not harm clothing or shoes, and it may be necessary to remove shoes and clothing to locate possible exit wounds. If EMS is not available, the electrical burns can be covered with dry, sterile dressings and gently bandaged. Fractures are splinted in the same manner as fractures caused by other mechanisms. In all cases, the patient is monitored continuously until the EMS providers arrive. Respiratory or cardiac arrest may occur on initial contact or within hours after contact. For this reason, medical aid should be summoned immediately. All victims of electrical shock should be examined by a physician. When the paramedics arrive, explain what happened and the care that has been provided. Since most electrical injuries can be prevented, taking the extra few minutes to assure that your home and work areas are safe can prevent needless pain and suffering.